Okay, we are going to go ahead and go back over chapters 1 through 4, just so that you can make sure that you've got everything that you may have missed, since I know that Monday was a trial for all of us. Anyway, so I'm going to go ahead and get started. We did not actually get through all of chapter 4, so we will finish chapter 4 as well. These are recorded, so of course you can go back and you can watch these just as many times as you need to, okay? All right, give me just a second here. I want to make sure that this is there we go, as big as we can. Okay, so chapter 1, we want to talk a little bit about our clients. Who are our clients? You know, what should we expect when we have encounters with them? Basically, what's this going to be like? Everybody has a little bit of a preconceived idea about what mental health itself is. You guys are going to have lots of questions. You're going to be a little bit nervous about coming in contact with people that are mentally ill, individuals that have problems that require inpatient hospitalization or extended care, even more so than with an individual that has a physical problem. So if we define mental health, we say that an individual is mentally healthy when their behavior, their interpersonal relationships, and even the relationships that they have within themselves show us that psychologically, emotionally, and socially that they're healthy, that they're okay, that they're content with what's going on with their lives. So much so that they're able to be independent, that they're able to be autonomous, meaning what? That they're able to do things on their own. They're able to make their own decisions. Okay, an individual that's mentally healthy is realistic about their abilities. They understand that they're not going to be able to do everything. They're going to be better at some things, and they're going to need to try a little harder at other things. Mental health also deals with a wide range of behaviors. And that's something that's important for us to understand. It's not just about emotions, but there's a great deal of behaviors that we look at when we're talking about mental health. And of course, it talks a lot about values. On page 4, box 1-1, you can actually look at this a little bit more in detail. So some of the questions that you guys are probably going to have is, what kind of people am I going to see? Are they going to be hard to talk to? Will I have anything in common with them? And if I do I need to be worried about that, right? How do I know that what I say to them might not actually cause them to become worse? You're not. Most of the time, interactions with them are going to be very pleasant. These individuals want to interact with other people, the majority of them. And the ones that don't, you'll know that as well. And how are you going to know what to say to them? Well, that's what this class is a lot about. So that's just some of the questions that you're going to come in that you guys probably have about mental health. So in addition to mental health, what's a mental disorder? Well, it's actually a lot of times a matter of judgment, as our book says. A lot of times we look at somebody who is different, or what we call deviant, which means that they're outside the norm from us, and we say that they might have a mental disorder. Okay? But again, it's a matter of judgment. What might be considered something that is deviant or that is a mental disorder among some people, or among cultures, or among values in different systems, might be very normal in another one. And it is still a matter of judgment, even when we know that brain chemicals are altered. When brain chemicals are altered, or when we believe that someone has a mental disorder, we refer to this as mental illness. So when an individual is having an exacerbation, or when they are truly ill, that's when it becomes a mental illness. Otherwise, we talk about individuals as having mental health concerns or mental disorders themselves. Individuals that have mental illness are going to exhibit significant distress, and at some point they're probably going to exhibit some disability, to the point that they might harm themselves or others. And the signs and symptoms of those mental disorders that they display are called psychopathology, which defined is actually the pathology of the mind, so the study of the mind. The DSM-5, which we talked about on Monday, is what I always refer to as our Bible. The DSM-5 actually was put into place the year 2000. We've had the most recent update actually was in 2014, I believe. American Psychiatric Association is who put this manual in place. On the right of this slide, you will see all the different disorders that are included. And these are going to be the ones that are going to have very definite definitions, signs, and symptoms. This helps us not just to be able to bill for our services, because realistically it does help us to do that, but it also helps us to treat. Some of these disorders and some of the signs and symptoms that we see overlap. So by having a manual or a guide or a Bible, something to follow, a lot of times it makes our jobs a little bit easier. Now, I don't think that I mentioned this actually last Monday, so this is important, or maybe I did, is that it's really important for you guys to understand that for a lot of these individuals, we really want to refer to them as clients, not patients. Now, you'll hear me refer to them as patients on a regular basis. Generally, that's because I work in a hospital. I work in an acute care psychiatric facility. So to me, when they are in an acute care facility, they are having an exacerbation of their mental disorder, so they are mentally ill. And to me, they're patients because we're providing them with acute care types treatments. When they are stable, when they're receiving ongoing care, then they become clients to me. Okay, so, and honestly, it's more politically correct for us to use the word client instead of patient. The term client, a lot of times, the reason that we like this is because it actually gives it actually increases the individual's overall self-esteem. Okay, it makes them feel more respected. And it gives them the optimistic belief that they actually have the ability to change. And sometimes by calling them a patient, they don't always have that. Okay. What's a comorbidity? A comorbidity is what? Something that that goes along with. A lot of times we say that a comorbidity is an additional illness or a second illness. Well, in this case, a lot of individuals have what we call comorbidities of mental disorders, meaning that they will generally have not just one, but two or more psychiatric disorders. For instance, somebody who suffers from depression a lot of times also suffers from anxiety. Because they're depressed, because they're anxious, a lot of times they will do what we call self-medicate. How do they do this? With the use of alcohol or other substance abuse. So there you have 3 different comorbidities, just like that. Okay? But comorbidity is defined as a co-occurring disorder. We know that a lot of research needs to look at, truthfully, the barriers that go along with this, meaning that a lot of times we don't have access to care for the individuals that we are trying to provide care for. And a lot of this even falls under the category of cultural barriers. Based on different cultures, we need to be able to make an adjustment so that we can take care of these patients in a way that they're going to be satisfied with. What about cost? Cost of mental health care is covered by insurance, some insurance, but a lot of times what we find is that it is not equal coverage. There are actually only a few states that have legislated what we call parity for mental health, which means that they are required by law to provide the same amount of coverage for psychiatric illness as they do for a physical illness. And a lot of insurance companies do not. They don't see that they are one and the same. They believe that somebody that has a psychiatric disorder, although there might be a chemical imbalance, that they still see that as being something that's just in their head, that it's not a physical, that there's not a physical component that goes along with that. So you might see that an insurance company might pay 80% for physical problems, but if somebody has to go in for psychiatric care, they might only pay 50%. Okay, that is illegal. But a lot of states actually do not enforce that. So what happens then is that individuals, of course, either don't seek care or they wind up paying out of pocket, and a lot of times they don't follow up because of that. Severely underserved groups in relation to mental health services include individuals that are substance abusers. Why? Because substance abuse is generally not covered by any insurances. That is going to be an out-of-pocket expense for an individual. And this is even for people that have Medicare and Medicaid. It is expensive to go through treatment. Older adults, especially if they happen to fall into a minority class, a lot of times uninsured persons and even homeless persons. These individuals, because of their lack of funds, because of the lack of access itself, are going to have very poor mental health service coverage. So what will they do? Nothing. They'll stay at home, they'll get sicker, and they'll wind up where? In the emergency room for an acute exacerbation of whatever's going on with them. So because we have all these underserved individuals, a lot of times we find that throughout the United States that we look at different areas and we determine how good are their services or how poor are their services. One of the mental health care services that has been a huge help when it comes to mental health itself is called the National Alliance for Mental Health, or Mental Illness, called NAMI. Demands for mental health services are increasing. At the same time, our nation is dealing with economic problems and state budget cuts. So we're seeing more and more people that are suffering from mental illness, and we are actually spending less and less of our per capita on taking care of these problems. When in reality, a large percentage of the individuals that we see for physical illnesses also have some sort of a psychiatric component. Not always, but even if it's just anxiety, a lot of times we're seeing this. So the National Alliance for Mental Illness, which is a resource, a true resource, it has actually done several different surveys, and it puts out a report that actually grades every one of the each state in the United States. And Alabama has a very poor rating. We actually have a grade of a D, which is poor, to say the least. Unfortunately, the national average actually was a D. No state received an A, and 8 states actually received an F. So unfortunately, that is something that we need to allocate more funds to, and it just doesn't seem to be working out that way right now. Let's look at a little bit at how mental health actually started, how mental health care got started. Individuals, at least initially, when we really started looking at mental health or lack thereof, people were pretty terrified of them. So what did they do? They put them away. They got them away from everybody. They didn't want anybody to see them. They didn't want them around anybody, particularly because they didn't understand them. They laughed at them. A lot of times they tortured them. And unfortunately, this is still something that we struggle with. This is stigma that we find with not so much the tortured, right, but the not understanding them, the laughing at them, even the ignoring them. And although we don't put them off by themselves so that they're their own little community, we do socially isolate them. So we still participate in some of these same behaviors. If you look in your book on pages 10 to 11, you can actually look at the timeline that actually shows the different kinds of shifting approaches to mental disorder throughout history, what kind of happened at one time, at different times anyway. In the early 60s, it was actually when individuals that were taken care of in the 60s, or prior to the 1960s, focused on their physical ailments. They really weren't focused on what was going on with them mentally. Okay, so if they weren't sleeping, or if they were losing weight because of their mental illness, if they had things that were physical that were a result of their mental illness, those kinds of things were treated. They didn't so much focus on that mental illness or what was the cause. If an individual was losing weight, if an individual wasn't sleeping, they weren't looking at what could it be that might be causing this to happen mentally. They weren't thinking about psychosis. They didn't know enough about it, and so they simply ignored it. So in the 1960s, actually, we saw a shift from what we called institutional care, where we had people placed in institutions, to we took a lot of these individuals out of the institution and we started treating them within the community. This, of course, is going to increase access to care, isn't it? It also gives us the chance to able to increase preventative services. So making sure that things are in place so that for an individual who's experiencing depression or for an individual that's experiencing anxiety, what can they do? They can go and they can see someone within their community and maybe get ahead on this before it progresses to a state where they wind up having to be hospitalized. In the 50s, in the mid 50s to 1975, we actually saw that state mental hospitals, residents that were in there actually decreased by about 60%. And this was because community health was becoming more and more popular, and because we truly saw the benefit of being able to treat these individuals within the community. In the 1960s, we actually saw a very important component of mental health care, which was family therapy. Anybody who has ever taken care of somebody who had mental health issues, or who comes from a family perhaps themselves, understands that it's not just the individual that suffers from that particular illness. It is something that affects the entire family. Entire families wind up having to take care of that particular individual in some shape, form, or fashion. If they're not able to work, then they may have to work more. If that individual has behavioral problems, then the whole family might wind up becoming isolated, making excuses for them if they're a substance abuser, different things. But you can see how it would affect the entire family, requiring a need for family therapy. What is stigma? Stigma is a negative consequence of being diagnosed with a mental disorder, unfortunately, and it is experienced at all levels. More so, though, in clients who are deprived, who don't have the things that they need in place in order to help to treat their illnesses. A lot of times we see that this is even more so even within our minorities. Stigma can do an immense amount of damage. It actually can lead to prejudice and even discrimination. It affects the judgment of family, of friends, of coworkers, because we all have this preconceived idea. And if we buy into that preconceived idea, a lot of times we wind up hurting that individual, whether or not that is intentional. For some individuals, it is truly intentional. They mean to punish them, or they mean to isolate them, because again, they don't understand. So we try very, very hard within mental health to be sure that we don't label people. So an individual who suffers from schizophrenia is not referred to as that schizophrenic. Okay, that his illness does not define who he is. Is it part of him? Of course it is. But by defining him as that mental illness, we are disrespecting him. We are setting him up for failure. Those kind of things. So it is very important that we remember that we don't label people, that we're very careful about that. And that's honestly an easy thing to do. And I do mean it's an easy thing to label people unintentionally. You'll hear each other refer to them. I saw a schizophrenic today, instead of I saw a client today who suffers from paranoid schizophrenia. Okay? It's something little, but it winds up being really a big deal. Okay? All right. I think I said this the other day, but I want to say this again. When I put this quote in here, Robin Williams was still alive. I just happened to like the quote. It's interesting to me that now that we have lost this amazing comedian who has truly impacted so many different areas of individuals' lives because of his comedy, and yet this man suffered from severe depression all of his life that eventually wound up taking his life. So his quote, I used to think the worst thing in life was to end up all alone. It's not. The worst thing in life is to end up with people that make you feel all alone. Knowing what we know now about Robin Williams, it makes you think that, did we let him down in some way within our society? Okay, that's the end of chapter 1. So let's go on to chapter 2. So give me just a second here. Okay. Sorry, I know y'all want to see my face. Okay. chapter 2. We'll share now. Okay. All right, and let me get rid of this again. Okay, chapter 2. Chapter 2, we want to look a little bit at psych nurses. Who are we? What do we do? Why would you be crazy enough to go into psych? Not when you're first out of nursing school, of course. This was something that I've done for a long time, but I actually had been a nurse for about 17 years before I decided to go into psychiatric nursing. Okay, so psychiatric mental health nurses. Who are they? Well, first you need to know that when it comes to psychiatric health, what roles different individuals are, the emergence of it, and what roles did individuals play when mental health actually became a true area of nursing. Of course, who's going to have a huge influence on it? Florence Nightingale, right? She actually spent a great deal of time taking care of psychiatric patients, because remember that she was a nurse that took care of soldiers during the Crimean War. Again, though, Florence Nightingale also still primarily focused on their overall physical problems, but she did recognize that there were psychiatric concerns and issues. And she understood that we most certainly needed to do something about it. The first American psychiatric nurse who opened the first American hospital when it came to psychiatric nursing was named Linda Richards. Now, I didn't say that in class on Monday. So hopefully you are watching this and you will remember that, because I promise you're going to see that again. Linda Richards, she opened the very first American hospital, and she is actually known as the first American nurse. Okay. They had what we called at that particular time single focus training schools, meaning that nurses who wanted to be psychiatric nurses went to a school just for psychiatric nursing. They didn't go to a regular nursing school and learn med-surg and learned OP and all that. It was just for psychiatric care, which, guess what, probably increased the whole stigma that goes along with mental illness, doesn't it? Because we're separating nurses. Now, it's important for you to know that mental health nursing or psychiatric nursing, it is a specialized area of nursing, but it doesn't necessarily have to have an entire school of its own. But at that particular time, it actually did. It wasn't actually until around the 1870s, so the latter part of the 19th century, that we actually started to see that that this actually, because this started, of course, with Florence Nightingale. So in the 1870s, we actually saw that this moved over to the States, and we saw there were actually 3 different schools that were open in states that were specific to psychiatric nursing. Just like now, because we do have an extreme shortage when it comes to mental health nurses, they did then too. There was always a shortage of nurses when it came to psychiatric facilities. The first American school for psychiatric nurses was actually called the McLean Psychiatric Asylum in Waverly, Massachusetts. I would remember that. I'm not so concerned, by the way, about you guys knowing specific dates, as just making sure that you know what occurred in the different eras. Okay. From the 1900s to the 1940s, they referred to this as, or this was actually where we started to see that within these psychiatric nursing schools, these single focus psychiatric nursing schools, we saw that they had a specific curricula, so that it was based entirely on psychiatric nursing, and we saw the emergence of psychiatric nursing techs. The reason that we saw psychiatric nursing schools was because people believed that physical problems and mental orders should be separate. Okay, so we saw them separate. We saw these single-focused psychiatric nursing schools because a lot of individuals said, well, you know what, they're not the same, and that we shouldn't be doing them the same. When what we know now is that a lot of times they're interrelated. Sometimes you can have a physical illness that does what? Results in a psychiatric in a psychiatric condition. An individual who suffers from chronic disease oftentimes also battles depression. In the 1940s to the 1990s, we actually saw a shift in that nurses started to begin to educate other nurses. We saw that now we were taking a closer look at how mental health patients were treated. We wanted to make sure that they were treated fairly, and we even saw now that it wasn't fair for us to separate both physical and emotional or mental health concerns. So we started to see now that it was being incorporated into regular nursing schools. In 1946, we actually saw what was put in place was the National Mental Health Act. And this is what truly helped with what we call the psychotherapeutic roles that nurses now play. So it taught them how to provide therapeutic interaction. Therapy is what they did. In the 1990s, they actually referred to this as the decade of the brain. So what does that truly mean to you? We saw lots of changes. We saw big changes in drugs. We saw all kinds of new drugs that were better, that were more effective, that had less side effects, because that's a big thing even now, is side effects. A lot of patient compliance or lack thereof is because of the medications that they take and the side effects that accompany them. We saw increase in healthcare delivery reform, meaning that there was equitable access, that there was a way for more individuals to be able to get care and to be able to get the same care across the board. We saw more of a focus on culture. We saw that we had to make changes in how we delivered care to different types of culture. And we actually saw that there was an integration of theoretical perspectives. So we were looking more at theories. We looked at the different theorists and the way that they addressed mental health concerns, and we utilized these as we were putting together our therapeutic environments. In the 2000s, which we refer to as the new millennium, we saw all kinds of things that changed, as well as the standards of practice. In 1973 actually was the first standards for psychiatric and mental health nursing standards were actually established. And we know now that there are actually two different sets of standards. They have a standards of practice and they have a standard of what we call professional performance. This standard of practice actually wound up contributing to what we call a knowledge explosion. We found out that there were all different kinds of aspects of mental health that we needed to expand our horizons on, that we needed to become more educated about. We saw that there was a renewed focus on physical health and the role that it played in addition to psychiatric mental health. We saw single points of entry. A lot of times when an individual is treated for a mental health concern, who's the first person that addresses it? Their primary care physician. Okay, so these individuals a lot of times would go in to see their primary care physician for depression or for anxiety. And although the primary care physician was not the expert, we still saw that they did a great deal of diagnosing and a great deal of administering medications, writing prescriptions for them, because that was what the client was most comfortable with. We saw advanced practice nurses coming into the setting. We saw them able to also do therapeutic counseling. We saw them be able to write medications. We saw them be able to do psychotherapy itself. And this, of course, is going to help to actually expand the practice settings and overall do what? Increase access to care, right? Whoops. In your book, you will see what is called the mental health team. It is actually in chapter 2, and it is box 2-1. There are, oh, excuse me, I'm wrong. I'm looking at actually the standards of practice, which you do also need to look at. Go back and look at them as well. There we go, the mental health team. The mental health team is actually under table 2-1. Okay, these are very straightforward. I'm not going to spend a lot of time on these, but I do want you to make sure that you go through and you look at your book. None of these are going to be a surprise, but I think what most people are surprised about is that it takes this many people in order to treat someone who has mental health issues. And that is, again, because mental health is something that we have to look at the whole person. It's not just the mental illness itself. There are social determinants, which I talk about all the time in public health, that you'll hear about, that contribute to an individual's overall mental health or their mental illness. Where they live, their education, how much money they make or how much money they don't make. Their genetic makeup sometimes puts them at a predisposed risk for some of these things. The family that they live with. There are a multitude of different things that actually contribute. So because of all of those things, we have to collaborate or work together with multiple different partners within a mental health setting in order to be able to provide the most effective care for these patients. So you're always going to see that. Team members themselves are going to include, of course, your psychiatrist, of course, your mental health nurse. You may have a nurse practitioner that falls under there, a clinical nurse specialist. Clinical nurse specialist is a master's level and advanced practice nurse whose focus is education. So she may educate the client on his illness. She may educate the family on the client's illness and what the plan of care is going to be and the best way to incorporate it, etc., etc. Clinical psychologist, a lot of times we may have that a clinical psychologist who actually, this individual is trained, of course, in mental health. They would have to do, of course, a clinical internship underneath the physician, but they're going to provide counseling. They're going to do therapeutic counseling. They may actually focus on behavior modifications. That's a big one. They have more time to be able to do those kind of things. Psychiatric social worker. Psychiatric social workers focus on things a lot of times like helping a client with disability, helping a client with resources that are out there, works with the family, helping to place them somewhere when they get home. If mom and dad or if their spouse or whoever says, no, they're not coming home, I'm done, we have done this multiple times and I just can't do it anymore. A lot of times the responsibility of somewhere to place them falls on the psychiatric social worker. If, for instance, that we are dealing with a married couple, which happens an awful lot, we may actually have a marriage therapist, or again, with families, sometimes we'll have a family therapist. We might have occupational therapy, we might have recreational therapy, we might even have creative art therapists. Why? Because they can all work together to be able to keep this individual busy. A lot of times they use all these different really cool creative techniques in order to be able to develop social skills, because for someone that is mentally ill, that is an area that they truly lack, is their social skills. By helping them, by making them more comfortable interacting with other people and even with understanding themselves better, this increases their chances of being successful in day-to-day life. And we also have the last one, which in your book it's called a rehabilitation worker or a psychiatric attendant. These individuals a lot of times do the day-to-day skills. They help them with the things that they're going to do on a daily basis, taking their medications, making sure to go to work every day, different things among that area. So they're doing not so much and they're not doing any kind of psychotherapy. They're helping them with their day-to-day living things. Okay, so effective mental health services are going to be composed of partnerships: the client, the family, the mental health team, as well as psychiatric mental health team. But make sure that you look at this in your book. Okay. Everyone works together in order to treat that client most effectively. Okay. You need to know that there are different kinds of healthcare team members. You need to know what a maximizer is. You need to know what a grabalist is. You need to know what a cooperator is. A maximizer, excuse me. These are individuals who are going to be interested in only their own gain. They're going to be there because, not because they care about the client, but because they're interested in what it's going to do for them. Is it going to get them a promotion? Is it going to move them to somewhere else? There's some sort of personal gain that is their only focus for them. A rivalist is someone that's only going to be interested in defeating their partners. So the people that they feel like that they're in competition with when it comes to caring for this individual, so what other team members, they a lot of times are going to be focusing on making them look bad, making themselves look better, that kind of thing. And then, of course, who we really want to have is what? The cooperators. Cooperators are those that are interested in helping not just themselves, but of course their partners, ultimately to be able to help the client. So make sure that you know what those are. Okay. All right. Nursing theories. We have theories for everything, right? So of course we're going to have nursing theories when it comes to psychiatric nursing. What do they do for us? Well, this slide tells us that it organizes our assessment. It helps us to identify problems. It helps us to plan interventions. It helps us to come up with goals. It helps us to be able to implement them and to evaluate them. What does that sound like? The nursing process, doesn't it? So nursing theories are a lot like maps for us. They're the nursing process. It's the things that we are going to put into place in order to help a person to rehabilitate or to stay healthy. Okay, so let's look at some of the theorists that were instrumental, especially when it came to psychiatric nursing. Hildegard Peplau, who we consider to be the mother of psychiatric nursing, believed in, or her theory anyway, was very similar to the nursing process itself. She had step-by-step nursing interventions that started out with anxiety specifically. She believed that when it came to the relationship between a nurse and a client, she believed that they had to create what we call a therapeutic relationship. They had to respect each other. They had to be willing to work together. They had to both be cooperative with each other. So she believed in a one-to-one nurse-client relationship. The teacher, of course, would of course be the nurse. The teacher would be the one that is going to impart knowledge. She would be the one that is going to help the client themselves understand the things that they may need to change or that they may need to work on in order to remain healthy. She also believed in what was called, or she actually wrote what was called the theory of interpersonal relations. And this theory had 3 different phases. We're going to talk about these a little bit more when we get to chapter 4, but you do need to know the orientation phase, the working phase, and the termination phase. The orientation phase, it says, is defining the problem mutually with the client. This is when the nurse and the client meet for the first time. Okay, this is where they meet each other. They set up what it is that they're going to be working on. They identify problems. They identify, they prioritize. What are going to be the things that are going to be most important for us during the orientation phase? They're going to set goals. They're going to develop interventions. During the working phase is actually where they are going to take those identified problems and they're going to take the interventions that they have deemed to be appropriate, which, by the way, that they've done together, right? You don't design a plan of care by yourself when it comes especially to someone that is a mental health patient if you want it to be successful. You need to include that particular individual in order for it to be as successful as possible. Okay, so having said that, the 2 of you are going to work together in the working phase in order to be able to take the problems that you have identified and to come up with alternatives or to implement the interventions that you've come up with during the orientation phase, and to basically, by trial and error, figure out what's working and what's not working. Okay. Once that we have come to a point in the relationship that we feel like that the client is able to, they have a good understanding, they have what we call good insight, they know what they need to do, they're comfortable with what they need to do in order to stay healthy, then it's time for them to participate in what we call the termination phase. And this truly is what it says. It's terminating the relationship that exists between the nurse and the client. That they feel, the nurse feels and the client feels like that the individual is strong enough to move on, that can address some of these concerns by themselves now. That doesn't mean that they won't still have problems, but what it does mean is that they have the confidence that they're going to be able to deal with them instead of becoming sick again. Okay, so Hildegard Peplau. Let's look at Joyce Travelby. Okay, she focused on the meaning in the nurse-client relationship. She believed that the way the nurse and the client interacted was going to determine success of treatment. So in other words, she said they've got to have a relationship. You meet people that you, as I like to say down here, jihad with, right? It's not realistic to think that every single nurse and every single client are going to be able to form a therapeutic relationship. It's not like that. We try, and generally speaking, by having that self-awareness that we're going to talk about in a couple minutes, that we are able to effectively and successfully work together, but that isn't always the case. So Joyce said that through this whole process of developing this relationship, she said that individuals that can develop a relationship, that therapeutic alliance, that therapeutic relationship, that they're going to be successful in being able to incorporate and to utilize this plan of care in order to help that patient get back to a healthy mental health status again. She really believed in the importance of communication. She felt like that if an individual with their nurse were not able to effectively communicate, which is something that all of us struggle with at times, that it was going to negatively impact that nurse-client relationship. She was, it says, motivated by compassion. She most certainly focused a lot on being empathetic. She believed that the nurse's responsibility was to walk the walk with you. So she said that they've got to be able to empathize, they've got to be able to put themselves in your place and what it is that you are going through as an individual. Your book mentions Patterson and Zerdad, and actually you have that slide. They actually felt that, and I really don't want to focus a lot on them, but I do want to mention quickly that they felt that what the nurse experiences during the relationship, whether it's good or bad, whether it's good or whether it's bad, ultimately is going to affect the course of the treatment itself. So I'll glance at that, but I don't have it on one of these slides, so it's probably not nearly as important as maybe Jean Watson. Jean Watson actually developed what we call the theory of caring. She actually was heavily influenced by Maslow. His concept of self-actualization, if you don't remember what that was, go back and look it up. Maslow believed what? That before you could reach self-actualization, which was the very top of the pyramid, you had to meet your most basic needs first. And you couldn't progress from one stage to the next until you were actually had completed and successfully completed whatever that stage was. So the first stage is what? Safety, right? And it moves up from there. So she was actually very influenced by him overall. It emphasizes the actual spiritual dimensions of the human experience. She also believed that you had to have that trusting and that caring relationship. She believed that the spiritual environment and the interconnectedness, as we call it, of everything, whether it was between natural healing approaches or self-knowledge or self-control. She believed that all of those things actually played a role when it came to your relationship and the relationship that you could have with other people. Her theory is actually congruent, or it runs alongside the more contemporary global approaches that we use nowadays when it comes to health and health promotion. So she believed a lot in doing things before they became a problem, looking at the things that contributed to having a problem or lack of communication, all of these different things. Whoops. Okay, so implications, which means what? What was the importance that these theories had? What was the potential as to how they would affect mental health nursing, these theorists? The theories that we just talked about had all of these effects on mental health nursing that you see listed here, like differentiated nursing from medicine. It put an emphasis more on caring and comforting rather than curing. Why is that? Because we understand that an individual that has a mental health concern, and at times a mental illness, it's never going away. Somebody that is that has schizophrenia, or an individual that suffers from bipolar disease, they're always going to have those things. Once you develop that, once you have that particular mental illness, they're going to have that. So our goal needs to be that we are going to stay on top of it, that we're going to keep it from worsening. We're going to educate our clients. We're going to do whatever we can in order to keep that particular condition from exacerbating. It places more importance on interpreting the meaning at the center of their theories. So in other words, we wanted to take the best parts of it and utilize them, to take the main idea, not so much to worry about all these other little things that interplayed with them. And what you'll find is that when it comes to mental health treatment, especially to therapeutic interventions and to even some of the psychotherapies that you'll see, is that nurses and counselors in general, a lot of them use bits and pieces of several different theories, and that's okay. It's whatever works for that client, and whatever seems to be the most effective, even for you as a healthcare provider. These theories, all of them, we know, focused on the interactions that occurred between the nurse and the client. And it advocated what we call humanistic and existential values of the client. So it looked at different things like dignity, freedom, responsibility, and even nurse authenticity. In other words, her truly caring. And they said that all of these things were really crucial when it came to quality of care. So sometimes we're going to see that. Sorry, give me just a second, guys. Let me plug this back in. Uh-oh. Okay. All right, sorry. Now I lost my train of thought. Okay, sometimes we're going to see that we have, that we're going to have to control really bizarre and even sometimes really destructive behaviors. And when we do that, sometimes we're not just going to be able to do that through psychotherapy. Sometimes it is going to require us to use medications. In fact, a lot of times most people think that that's our primary, that's the way that we primarily treat patients, when in reality that isn't the case. In reality, we should be using a combination of both of them. That is just so that when we do use medications, our purpose is that we can actually get them back to a point where we're going to be able to develop that relationship with them. So a lot of times we use medications as a tool to enhance that relationship and to make that relationship more effective. Okay, so that's it for Chapter 2. We'll move on to Chapter 3. Okay. Here is Chapter 3. So we're going to talk a little bit about self-awareness, how we see ourselves, what kind of things are important to us, what are the things that mean something to you, that guide how you think, as a nurse, as a person, as a parent, as a child, whatever. We're going to look at these things. These are things that we all struggle with. But in nursing, this is something that we have to be especially conscious of. Okay. Self-awareness. All right, let me get rid of this real quick. Okay, so what is self-awareness? Self-awareness truly is, like I said, how we see ourselves, how we, our values, our morals, the things that are important to us. It is influenced by the way that we see ourselves. So the things that we think that are important, the things that we do in our day-to-day lives that guide us, the things that our parents have taught us over the years. These things are all it all influences the way that we see the world. Attitudes, values, expectations, and beliefs are included in this, both personal and in what we call our professional identity. So the way that we see ourselves when we're with our friends or with our families, and the way that we see ourselves and the way that we behave as a professional. Self-awareness and self-reflection are critical to effective, compassionate psychiatric care. The hardest part for me as an individual when I first started psychiatric nursing was to be able to do what I called check my feelings at the door. To be able to say, it doesn't matter how or what I believe about this particular situation, I have to be able to treat this client with the respect and with the compassion and the empathy that I would want somebody to treat not just me, but my family members as well. Okay. So in order for us to be able to understand ourselves, to be able to look at those things that are important to us, we have to look at our feelings, our thoughts, and even our behaviors. And it says what? You're encouraged to attend the mind, body, spirit of your clients. So in other words, the things that are important to them, it's a good thing for us to learn why those things are important to them. Doesn't mean that we have to agree with them. No, that's not what it means at all. But what it does mean is that we do have to respect them and the roles that it plays in their lives. Okay. So a big part of understanding ourselves is assertiveness. Assertiveness, or being assertive, actually means that you're able to stand up for yourself and you're able to stand up for other individuals if needed. Okay? You have to be able to do it calmly, and you have to be able to do it without being aggressive. And sometimes when our emotions are at high levels, this is very difficult to do. So there is a little technique, and I like this technique. I like the way that this goes together, these little 5 steps, so that's why I have this in there. So I want you to remember it this way. Okay? In an assertive technique, the first thing that you're going to do is you're going to get an individual's attention. I'm going to give you an example in a second. The second thing that you're going to do is you're going to express concern. The third thing you're going to do is you're going to state whatever the problem of the concern is. The fourth thing you're going to do is to propose an action. And the fifth thing you're going to do is to reach a decision. So let's just say that you are a nurse and you are working in a hospital and you're taking care of a client who, let's say that doesn't even have anything to do with mental health. Let's just say that they're experiencing pain. Okay? And by whatever reason, the nurse is very busy. She's got several different clients. Maybe she's just not paying attention in general. You're concerned about this patient getting better, or about this patient getting effective pain relief. So how, and especially as a student, how would you address that? Okay, so you may walk up to her and say, Miss Smith, I'm worried about Mr. Jones's pain he's having. Mr. Jones in room 120. I'm worried about the pain that he's having. He's actually rating his pain a 7 out of 10. I'm just wondering if I see how busy you are. Would you mind if my instructor and I took the pain medicine that's prescribed for him on a PRN basis and went ahead and gave it to him? And the nurse may say yes, or the nurse may say no. And in this case, we're going to say that the nurse says yes. Okay, thanks. We're going to do that. So you see how calm and polite she got the nurse's attention. She told her what a concern was, is that the patient was having pain, and stated the problem by saying that the pain was at, what, a 7 out of 10? What was the action that she proposed? That she would give the medication. Okay? And of course, the decision is, in part, going to, of course, be made on both of them. The nurse doing it and the nurse agreeing to let that nurse do that. Okay, so you see how that's just a good way to look at it. Those 5 steps are an easy way to kind of, because you know what, being assertive isn't easy. Some people are fairly good at being assertive, but some of us are more passive. I don't think anybody's ever called me passive, but I most certainly I have 3 children. 2 of my 3 children are very passive. My husband's very passive. So being assertive is a technique. And that's what it is, a technique that you have to learn a lot of times. Okay, so how does, when it comes to our overall when it comes to our self-awareness, what role does culture play? We find that culture is composed of what? Heritage, sociocultural heritage. The things that we believe, the things that we hold dear, our beliefs, our values, our attitudes, a lot of times are directly related to our culture, right? The things that are important to you, you generally learned from who? Your parents, right? And although some of them may have changed a little bit over the years, by far and large, the majority of your beliefs and your values came from your family. So that is part of your culture, part of your heritage. Okay, there is a big potential for misdiagnosis by not understanding somebody's overall culture. Things that we may see in an individual's culture that's different or that maybe that we don't agree with does not necessarily mean that they're wrong or that they're detrimental to the patient's health. So it's important, again, that we understand not only what's important in another individual's culture, but what's important in our culture. What are the things that are important to us? Because when we see things that are different from our own culture, a lot of times we have a misconception that everybody has those same beliefs. Okay? All right, so having said that, how are we going to avoid that? By getting what this slide says is called a cultural profile. If you're taking care of somebody who is Hispanic descent, I wouldn't suggest that you walk in to take care of that individual knowing absolutely nothing about their culture, because there are a lot of faux pas that we can make. So being smart about it, checking it out, and a lot of that has to do with respect too, doesn't it? Having enough respect for that individual that you want to know what's important to him in his culture. Okay, moving on. Empathy. Empathy is a huge thing in nursing, and especially when it comes to psychiatric nursing. And part of this is because it's hard for us, for especially some of these different conditions, to be able to empathize or put ourselves in their place. This is my dog, guys. Say hi to him. So don't forget about how important empathy is and why it's important for us to maintain it. Empathy, it says, is accountability for one's behaviors and actions in situations. You have to have empathy, because if you don't have that, it's going to make us an already stressful situation even worse. You're going to see that client is going to probably shut down completely. If you can't respect them and you can't empathize with them, it's going to be very difficult to be able to maintain or to create that therapeutic relationship. Okay? All right. So I think, in fact, I know I did, and we've already talked about empathy a couple times. In Blackboard, underneath, I think I put it under resources or tools, something like that. Anyway, it's on the left side of when you're looking through all your stuff. You will see that I posted a little video. It's about 3 minutes long, 2 minutes, 50 seconds on empathy. It's a great little video. Sit down and watch it. There is a big difference between empathy and sympathy. Okay? Do we want to sympathize? Sometimes, but we're way more effective as healthcare providers and as advocates for our clients when we can empathize with them. So sit down, watch it. It's a cute little video, but it's well worth the 3 minutes. Okay, lastly, taking care of ourselves is also really important. Said that if you are an individual that is not assertive, develop it, practice it. After you do it a few times, that being assertive, not being aggressive, right, but just being assertive, you'll find that will come easier. Make sure that when it comes to ourselves, that we do take time for ourselves. We want to make sure that we're taking care of ourselves physically. We want to make sure that we're taking care of ourselves mentally, making sure that we can recognize signs and signals of stress. Sometimes seeking solitude, as it says, or being off by ourselves helps with those things. Being with somebody that you care about, that's important to you. You have to take care of yourself. You have to be able to take care of you first before you can take care of someone else. And we tell caregivers and clients this all the time. I have caregivers, or especially as a hospice nurse, I had caregivers that they would spend 24/7 with these individuals that were terminally ill. They never took any time for themselves. And the next thing that you knew, they were sick because their immune systems were affected by lack of care for themselves, or they wound up having a mental breakdown themselves because of how stressful that it was. So making sure that we can recognize the things that increase our stress levels and making sure that we can do something about it is vital to being able to not just do this kind of nursing, but nursing in general. Why? Because ultimately we worry about what? Burnout. Burnout is extremely high in psychiatric nursing. Lots of psychiatric nurses last more than a couple years because it's very intense. You are dealing with people who are deeply troubled. Some of them are what we call repeat offenders. You get them on the right path, you get their medications for them, and they go right back and they do the same thing. So for those individuals and caring for them, it becomes very difficult. You don't a lot of times see that, you don't have that warm fuzzy feeling. And so being able to care for them a lot of times increases the likelihood of our burning out. So if we can recognize those cues, a lot of times we can actually reduce the risk of burnout. So doing those things that we talked about a few minutes ago, taking time for yourself, those kind of things, those are all important. Okay. Last chapter is chapter 4. Hey, what time is it? 4:42. All right, chapter 4. So we talked a little bit about who our clients are, what kind of nurses do this. We talked about ourselves and how we're going to be an effective nurse. Now we need to talk a little bit about the actual therapeutic nurse-client relationship. So how do we form these relationships? If you have already done some of your clinicals, and some of you have found that there is a certain amount of challenge that goes along with being able to develop a relationship with these clients. So how do we do that, and what is it? We call these, of course, a one-to-one relationship. It facilitates useful change in a client's life by forming this relationship. And how do nurses do it? Well, they use what we call interpersonal skills. They use different techniques by interacting with each other. That's the interpersonal skills part. We use our personalities, and we even use the personalities of the individual that we're dealing with to be able to determine how we're going to facilitate this particular relationship. We use theory. We use that to be able to help to guide us and to develop the most therapeutic relationship that we can. Okay, so there are different types of relationships that we have. A professional relationship, we may have a professional relationship, especially with a client or with a patient. This one-on-one relationship understandably has to be what we call mutually defined. Okay, so these are your expectations of me. These are my expectations of you. These are the expectations that we have of this particular relationship in general. Okay, this is what we want to get out of it. This is what we're hoping to do. How do we do that? Through collaboration, right? We work together. I said earlier that incorporating a plan of care when it comes to somebody who is mentally ill has to be done together. Not just the mental health team, but with the client themselves. Allow the client to be able to help you to determine what's going to be most effective for them. And a professional relationship, when it comes to this, should be what we call purposeful. So we purposefully form that relationship, okay? And it should be goal-oriented. So what we're really trying to do when it comes to this professional relationship is we're trying to create what is called a therapeutic alliance. So we're going to work together. That alliance is that we're going to become a team, and it is in the form of a therapeutic manner. It The therapeutic alliance, the way that we do this is by creating that conscious relationship. Okay, so we sit down and we actually have to work at it. It doesn't just happen. Okay, it's not a spontaneous relationship. It's something that we set out to accomplish. It focuses on growth facilitating aspects of the client. So it looks at the things that are going to help them to get control of what's going on, to help them to improve their overall situation, their overall health. And by doing all of these things, by letting the client utilize the assets that they have, because they do have some, no matter how sick they are, they do have assets, they do have strengths. By being able to identify and to incorporate these things, we're going to be able to form that therapeutic alliance. If we can form that therapeutic alliance, that partnership is how I look at it, it's going to help to improve the chances of them not just recovering, but of course getting better and to a functioning status that is acceptable not just to them but to those people that are around them. It helps them to control or to lessen the negative aspects of their mental illness. So there are a couple different types of professional relationships, and you need to know the difference between them. There we have what are called informal professional relationships and formal. Informal generally is going to be, it's going to happen spontaneously. Okay, this is like a nurse that is taking care of a patient who is having a baby, or you're a nurse in the ER and you have a client that comes in a car wreck. Okay, you're going to have a set number of interactions. You're going to have a limited time, and you're going to have minimum structure and a sense of immediacy. So everything's going to be very short term in an informal professional relationship. For instance, if you are working in the ER, and let's say that you have a mother that comes in and that's in labor, okay, you know that your interaction with her is going to be to make sure that if we can't get her to OB, because that's of course going to be our first goal, and that we're going to make sure that we have everything together to make sure that you have a safe delivery for mama and baby, okay? And how is it going to be done? Very quickly, right? Whereas in a formal relationship, it's going to require a lot more planning, a lot more structure. It also requires more expertise by the nurse, and it is more time consuming. This is a lot of times what we see in crisis intervention. So a client that comes into the hospital, okay, that maybe they come in because they've had a psychotic event, might start out as an informal professional relationship, but as we stabilize that client, we give them medications in order to treat the psychosis. Now we look at it becoming more of a formal professional relationship because we're looking at it more long term. Now we're going to see what we have to do in order to get them home, to get them back to a level where they can function daily, be able to either go to their job or be able to take their medicines and to interact with their families. You see what I'm saying? It's longer. It has goals that are going to be it's going to have more long-range goals, for lack of a better word. These kind of professional relationships have to be what we call committed. Okay, so in other words, there has to be cooperation on both the part of the nurse as well as the client. It is going to, this commitment or this dedication to be able to work together is going to establish limits of the relationship. If we're truly committed, it's going to tell us how much time that we're going to put into this relationship, how much energy. It's going to tell us what our specific roles are as well as responsibilities. But we have to be really careful that although we want to be committed, we don't want to be overcommitted. Okay? We want the client to be able to sufficiently express their feelings by themselves. We don't want to be doing everything for them so that we're more or less interpreting those feelings. They need to be able to come to that conclusion on their own. We want to guide them. We want to facilitate that relationship, but ultimately we want them to arrive at those conclusions. Be very careful not to assume what we call an omnipotent role, not all-knowing, coming across as that, listen, you just need to do what I'm telling you to. We need to be careful about being the rescuer as well. This doesn't benefit our patients. It makes them more dependent on us, and a lot of times we see increased levels of manipulation from this. By doing this, by being that rescuer, you know what, don't worry, you're going to be just fine. I'm going to make sure that everything, you know, that you get your medicines, that when you get home, that everything is set up just like you need it to be. That's not our job. Our job is to encourage them. Our job is to help them to identify the strengths that they have and to give them the power to be able to make their own decisions. You want to give them self-efficacy. We want them to believe that they can make these changes, because if they can't, then they're going to be right back in this position again. So there is what we call phenomena, or that there are things that we're going to see that actually occur in one-to-one relationships, and we're going to talk about all of these. Resistance is actually the main category. Okay, underneath that category, these are all actually forms of resistance, fall acting out, transference, countertransference, and conflict, and we're going to talk about all of them. So let's just talk about resistance in general. Resistance, an individual's resistance in, now remember we're talking about forming this therapeutic, this one-on-one relationship. Resistance is going to interfere with, and it's going to disrupt the smooth flow of feelings, memories, and thoughts. It's going to inevitably surface in the course of one-to-one work, meaning that there's going to come a point when you are developing and forming this one-to-one relationship that is going to be uncomfortable, that is going to require you as a nurse and the individual as a client or patient to address things that they're going to have to accept responsibility for themselves, that they're going to have to take a second look at, and sometimes that's really difficult, especially if it's something that's painful for them. And the easiest way to not have to deal with that is to resort to resistance. This, a lot of times, it says resistance occurs when the client begins to address self-defeating thoughts, feelings, and behaviors. And that they are, a lot of times it occurs when they're struggling against anxiety that's associated with change, with self-awareness to taking responsibility for actions. So let's say that an example of resistance might be that let's say that we want an individual that we're working with them to be able to go back home, to be able to take their medications, for them to be able to live independently, and for them to increase their social interaction. Okay? For many, many people, whether they are mentally ill or not, change is very anxiety provoking. So why is this a problem, especially for individuals that are mentally ill? Well, because for individuals that are mentally ill, a lot of times it's anxiety causing situations that causes them to exhibit what we call resistive behavior, and it exacerbates their overall disease process a lot of times. So when we're looking at things like we said, self-defeating thoughts or self-defeating behaviors, telling them that as we're putting these things, we're discussing, this is, this is how we're going to put these things in place. What do you think about that? I can't do that. I'm not going to be able to do that. I'm not smart enough. I'm going to get frustrated with it. That's their way of saying that they just don't want to deal with it. Doesn't mean that they can't, but those are things that we have to recognize, that we recognize that these are hurdles for them to overcome, and for us to be able to help them to overcome those hurdles. All right. So resistive behavior, we discussed what it is. So how is it manifested, or how are we going to see it? Okay. Resistance is usually described as a client's unwillingness to, first of all, recognize feelings, fantasies, and motives. Okay, so if a person is having those self-defeating thoughts, or if a person is having those negative types of thoughts and you call their attention to it, a lot of times they're going to decline that. They're going to deny that. That's not what this, no, that's not why. I'm not afraid of change. I'm not afraid of this happening. I just don't want to do it. Okay. Sometimes it is their unwillingness to reveal those feelings to the nurse or to the therapist. They're not ready to talk about them, or they're afraid of how the nurse or the therapist may see them. It's their unwillingness to demonstrate self-sufficiency or independence. Because for a lot of clients, and I shouldn't say a lot, for some clients, the clients that are exhibiting resistive behavior, for a lot of them, they are dependent. They want to be dependent. They feel safe that way. It's scary to think that now they're going to be responsible for themselves. Okay? And it's their unwillingness to change behavior outside of the nurse-client relationship. So where they're in what I like to call a little bubble, this secure little bubble, they know that eventually that they're not always going to be in that. And it's scary for them to think that they're not going to have that nurse or they're not going to have that therapist there in order to help to guide them. When we see resistive behavior, we need to talk about it. We need to talk about it with the client because sometimes they do it and they don't even realize that they're doing it. So talking about it with them openly or discussing it with them is a much more effective way of being able to help that patient or that client to progress in their overall process. If we ignore it, then we're going to be stuck there and we're not going to be able to help them to move on. Okay. Acting out. Okay, we said that acting out is what? Is a form of resistance. Okay, in acting out, the client their behavior is actually putting into action a lot of times a forgotten or repressed memory. It's going to be inappropriate. It might be yelling, it might be hollering, it might be throwing chairs. It's going to be something that is going to be inappropriate and unacceptable. They a lot of times are acting out feelings and attitudes even towards the nurse that sometimes are associated with other persons. So what I mean by that is if they have, if all of a sudden a memory that they have from childhood, let's say that they have a memory about a parent who is very abusive and it causes them a high level of anxiety and they start to act out. A lot of times, who are they going to act out towards? The nurse. Why? Because she's there. They're going to act out the feelings that they're having and that, like we said, that are associated with other persons, in this case his father, and it's going to be acted out towards the nurse. What happens when an individual acts out is that, of course, if it happens to be during treatment, it's going to disrupt it, of course. If you are sitting, whether it is one-on-one or whether it is in group treatment, and all of a sudden we start to see this acting out, we need to stop it. We need to call attention to it. And we need to talk a little bit more about what it is that might be causing them to believe this way, to behave this way. Acting out, actually, believe it or not, can help clients understand what it is that's causing them to act out, what it's associated with, and eventually, by being able to identify and to name those kind of things, it helps them truly to quit having those kind of behaviors. Sometimes it's just simply drawing attention to it. Specific nurse interventions for acting out behaviors, what are we going to do? Well, we're going to encourage them to talk about it rather than acting it out, because of course it's much safer that way. We're going to encourage them to talk about the feelings that they're having before putting them into action. Okay, I'm really angry right now. I'm angry because da-da-da-da-da-da-da, instead of picking up a chair and throwing it across the room. Okay, increasing frequency of contact is also something that a lot of times help with acting out behaviors. Sometimes it is attention seeking, but by increasing that contact with them, a lot of times it helps them to feel more secure. It helps them to understand that you are truly committed to what's going on. We're going to look for evidence of transference, which we'll talk more about in a second. It is very important that when it comes to acting out behaviors or resistive type behaviors, that we set limits, that they understand that that kind of behavior is not acceptable and what the consequences will be. Okay, not treating them like a child, okay, but setting very specific limits on that. It's not acceptable to throw chairs. If you throw chairs while we are in group or at any time while you are in this facility, you will be removed from the presence of everybody else, and you will be taken to your room, or you will be separated from everybody else. Okay? If you cannot control your behaviors, or you cannot control the way that you are speaking, then you will not be able to go outside. Okay? That's setting limits. Right? It's not taking away privileges. It's being very clear about what will be the result of that type of acting out. Now, does it always work? No, it doesn't. So we have to make sure that we are, just like with children, that we're consistent. And if that particular behavior continues, especially if it's dangerous, then we have to understand that we may need to terminate that relationship, especially because a lot of times, like we said, it's focused towards who? The nurse. Okay. Now, because, as you can imagine, that this is going to be a highly emotional type of situation, sometimes as nurses we don't respond appropriately either. Okay, so what would be some inappropriate nurse behaviors? Okay, for one thing, we shouldn't encourage acting out behavior by taking especially the role of a parent, placing your hands on your hips, pointing fingers at them while you are setting limits on a client's behavior. Yes, you should set those limits, but please remember that you are talking to another adult. Whether they are acting like an adult or not, they are still an adult, and they should be treated with respect. It is condescending for us to behave in a parental role towards another adult. Patting a client on the shoulder and offering reassurance. Again, this is a parental type of behavior, but it's also inappropriate. It's really, truly letting them know that their behavior is actually okay. Dressing suggestively is inappropriate. This truly, nurses that, and honestly, you don't so much see this as nurses, but even in other mental health professionals, we actually had a member of our therapy team that she dressed very suggestively. When she came in, she wore very low-cut blouses, she wore clothes that were very tight. This, unfortunately, in patients who are oftentimes very hypersexual, will cause them to act out. Blushing and giggling when a client makes a sexual remark, that is not okay. Those kind of remarks need to be addressed immediately. Mr. Johnson, I'm not going to tolerate you talking that way. If you cannot talk and be respectful, you will be asked to leave. Okay? And then, of course, being sarcastic in response to a client's concern, or being hostile towards them, because truly sometimes your frustration level elevates too, and sometimes we do sound sarcastic or even patronizing, and it comes off as us being hostile towards them. So we know it's inappropriate. What are the things that we're going to do? So the first time that an individual acts out, or that we see resistance displayed, does not automatically mean that we're going to chart that this patient has resistant behavior. Okay? This patient displayed acting out behavior in the form of da-da-da-da-da-da. Okay? If the patient continues to act out, throwing chairs, da-da-da-da. So it should occur several times before we actually label them as having that resistant behavior. We need to look at what's the reason. Talk to that client. Ask them some questions. Let them talk to you about their feelings. Figure out, do a little research, so to speak, about what it is that might be contributing to these kind of emotions. Explore the functions that resistance may serve. Okay, is this acting out for them, helping them to feel like they're more in control? Okay, is it making them feel like that they're able to get what they want, that it's fulfilling that attention seeking that maybe that they crave? And then facilitate working through resistance by helping the client to understand and to appreciate implications. So help them to know why that their behavior isn't acceptable, helping them to understand what it might be that's causing it, and how to be able to change that behavior to make it more positive for them. Okay. All right, let's talk a little bit about transference. Now, again, this is a form of resistance. Okay, transference is typically, or it's described or defined as unresolved feelings, attitudes, and wishes from childhood experiences with significant others are transferred into present significant relationships. Oftentimes, that significant relationship is going to be with you as the nurse. Okay, so you are going to be the one that they're going to have the transference towards. It's unconscious. Okay, so that individual does not realize that they are having transference resistance. Okay, but it's unconscious resistance of childhood conflicts, and it's in an attempt to resolve them in a more satisfying manner. Okay, so an example of transference might be that maybe they lived with a parent who was highly critical of them in everything that they did, in their grades, in the sports that they were in the way that they made their bed, in the way that they dressed. Okay, and for some reason, they are actually transferring that vision or those feelings that they had towards that particular parent onto you. Now, does that mean that you're behaving that same way? No, not necessarily. It doesn't mean that at all. It just means that that's how unconsciously the client is actually, that they're making that association with those feelings towards you. Okay, so therapeutically, what's the therapeutic task, as we refer to it, that's going to help us? Well, we're going to identify those unresolved conflicts in past relationships. How are we going to do that? We're going to ask them questions. Tell me about your childhood. What was your relationship like with your parents? Asking questions, and you'll be surprised. What was your relationship with like your parents? My father was really difficult to live with. He was always telling me what to do. He was always telling me that I wasn't good enough. He was always telling me that I was never going to amount to anything. Okay? Then you're able to, once you've identified that, to be able to separate those feelings, those thoughts, and those behaviors, and how that they are affecting or how that they relate to that one-to-one relationship with you now. And that will most certainly help you to address it in a more positive manner by helping them to understand that, so that if they feel themselves starting to participate in some of those acting out or those resistant feelings that are related to transference, that they'll catch themselves. Okay. Countertransference is also a phenomena that we see in resisted behavior, and this actually is unresolved conflicts by the nurse. It involves, it says, counterproductive fantasies, feelings, and attitudes towards the client. Okay, so this might be that this particular patient, let's say that you're taking care of a patient, and perhaps they remind you of somebody that was very highly critical of you in your younger years, or somebody that that you just had that you had a poor relationship with, and you attribute those same kind of conflicts, or you push those same kind of conflicts onto that patient. And what happens is, of course, that we treat them in a non-therapeutic way, right? It affects the way that we interact with them. It might be in the form of omission. So maybe not interacting with them as often as we should, avoiding therapeutic interaction with them because we just don't like them. Or it can be in the form of commission. So maybe not giving them their PRN medicines because they're telling you that they're having increased instances of anxiety, and all you can remember is your mom, who was popping pills all of the time when you were younger because she said she had so much anxiety. Now, I'm just pulling an example, okay? But how do we resolve this? Well, usually it's going to be somebody else is going to observe it, okay? Of course, it's going to be self-assessment. If you have negative type feelings towards a client, it is really up to you to take a step back and to say, wow, what is it about this client that is pushing my buttons? What is it that is making me feel this way? Sometimes just that realization that, although you might not know exactly what it is enough to be able to help you to rein back in those feelings, to be able to practice that self-assessment and to check your feelings at the door and to move forward. And sometimes it does require professional supervision. going to somebody that maybe a coworker or maybe one of the counselors and saying, you know, I'm really struggling with this. This is why I'm feeling this way, or I'm not sure why I feel this way. So sometimes some professional intervention sometimes can help us. So the point of our one-to-one interaction, our therapeutic reliance, is to establish a contract. Okay? And of course, a therapeutic contract. So this contract is exactly what it says it is. It is a negotiated, identified plan of action. So a plan of care. It's going to have short-term goals. It's going to have long-term goals. They need to be specific. They need to be detailed. They need to have identifiable, observable outcomes. Okay? And not only that, but we have to have an evaluation tool that's in place in order to be able to determine the benefit of the relationship to the client and the effectiveness of the nurse overall. So we put evaluation tools in place so that at the end we can look at this therapeutic plan and say, okay, was this beneficial to the client, and how effective was the nurse at being able to deliver it? So we do this through different phases. Okay, so the orientation phase, really, let's go back just a second. The orientation phase is really where that therapeutic contract is going to occur in that one-to-one relationship. Remember, we talked about orientation, working, and we talked about the termination phase. So the therapeutic contract really actually occurs in that first phase. Okay, so now we're moving on to the second phase. Everybody's identified what their responsibilities are, whether or not that they're committed, how committed they are, et cetera, et cetera. Now we're moving into the working phase. Okay, so in the working phase, this is where we maintain and we work on the relationship. Okay, this is where we're going to look at the contract. We're going to incorporate the things that we have identified. We're going to work on those things. We're going to address things like developmental changes. We're going to look at different situations. We're going to look at maybe problems that we have interpersonally, so with other individuals. Okay, we're going to look at those things. We're going to identify what we need to do, and we're going to implement the things that we have established to work on those things. We're going to explore them. We're going to make the connections. This is what this is in the past, what has caused me, or what we think has contributed to this particular type of behavior. And by using this established intervention, we're hoping that we will be able to decrease that overall dysfunctional behavior or that negative outcome that we had previously. So we're working on things. In addition, we're also going to be doing what we call a behavioral analysis in order to be able to have that constructive change of behavior. So the behavioral analysis, which we said was the goals during that working phase, is going to look at the dynamics of dysfunctional response patterns. What are the things that are occurring together that are resulting in this dysfunctional response pattern? So maybe it is that they are having their medication compliance. Okay, maybe we're having problems with their medications. So we are going to explore what are the things that are occurring at home that are causing them ultimately not to adhere to their medication regimen. And we find out, oh wow, there's nobody there at home. And sometimes I forget whether or not that I should be taking those medicines. So I don't want to take too much, so I don't take anything. Or there's nobody to go to the store to get my medications. Okay, so those are some of the dynamics that are contributing to that. And then we address the dysfunctional thought and the emotive patterns. So based on those particular dynamics, they're saying, you know what, so because half the time I really have to work hard to try to find somebody to help me with that, and I can't, I'm never going to be able to do this. There's your self-defeating behaviors, right? Never going to be able to do this, so why even bother? I'm just going to be crazy for the rest of my life. When in reality, the nurse and the client are going to take that behavioral analysis. The reason that the non-compliant behavior is occurring is because of these things. And now what we're going to do is we are going to incorporate these interventions in hopes that it's going to change that behavior. Well, you know what? We said that that was one of the problems that you had. You're non-compliant with your medicines. How are we going to fix that? Well, we're going to use a pharmacy that delivers. Okay, that's a great idea. And how about if we use a pill box to put all your medicines in so that you can look at those medications, and we're going to put them all in there for a week, okay? So that we can look at each day and we'll know whether or not that we took our medicines. That seems logical, doesn't it? Okay, and you do it together. Okay, all right. Does that make sense? Is it all kind of gelling? Okay, so that was the working phase. Now we're going into that last part, that termination phase. This is where we're going to actually end that relationship. We're going to do it in a mutually planned and a satisfying manner. And you know what? Don't be surprised if you see some regression, because a lot of times that's very normal. And not even just for them, but for us as well. It's very important, because this is highly emotional, that we address this in the very first part of our relationship. So in that orientation phase, we're going to talk about it right away then. We don't really want to focus exclusively on the separation. We want to focus on the things that we've accomplished and the plans that we have in place for them, the things that are going to keep them successful in what they've already done. We want to allow the client adequate time to be able to work through those termination feelings, and the nurse should be able to explore her personal reactions that she had with this client with professional colleagues, because it helps her to work through the termination as well as to develop plans and ideas for future therapeutic interactions. So, okay, so assessment. Assessment, we're talking a little bit about the nursing process now, right? Assessment is the first thing we do. So how, when it comes to these three phases, what are we going to do in assessment when it comes to the orientation, working, and termination phase? In the orientation phase, when it comes to assessment, this is where we're doing what? We're initiating that trust building, and we're establishing rapport. We're getting to know each other. So how do we do that? Well, we're going to obtain relevant, objective, and subjective client data. Okay, simple things like asking them subjectively to tell you a little bit about, why are you here? What's been going on? Noticing things like what their strengths are. They're very open. They maintain good eye contact. The things that you know that are going to be focuses for you. Maybe they don't maintain eye contact. Maybe, according to their blood work, you can tell that they've not been taking their medications, even though they're telling you that they are. Okay, but this all helps to build and to establish rapport. Okay, that's what's going to occur for assessment in the orientation phase. For assessment in the working phase, we're going to continue to collect those kind of things. Okay, we're going to continue to collect, and what I like to say is we're going to get more of the nitty gritty. Okay, in the orientation, we're going to get a lot of that superficial stuff. Tell me, how many brothers and sisters do you have? Okay, tell me a little bit about your family history. Whereas in the working phase, we're going to look at them, the ones that we have identified, if we're talking about family members, that we're going to have identified that we know that, or that we suspect that there might be a connection between what's going on. And we're going to ask them more in-depth questions. We're going to ask them what we called in health assessment focused questions, right? And then, of course, again, in the termination phase, we're going to be assessing whether or not that person is ready to terminate. Okay, so have they accomplished what it is that they've set out to do? Now, that doesn't mean that they don't have a problem anymore, but that does mean that they are comfortable in the new skills that they have started to learn. Okay, that they are on their way to recovery. Orientation phase, when it comes to nursing diagnosis, NANDA approved, are going to be, an orientation phase is going to be that where we're going to formulate that preliminary nursing diagnosis. Okay, so remember, nursing diagnosis, non-medical diagnosis, anxiety related to. Okay, look for dominant themes or central issues in the client's responses. Are they cooperative? Do they maintain eye contact? Different things. In the working phase, of course, what are we doing? We're revising. We're continuing to evaluate, because we may have to change our nursing diagnosis. Might have to reprioritize that change throughout the whole process. In the termination phase, when it comes to nursing diagnosis, we said that sometimes we might see regression, right? So in the termination phase with nursing diagnoses, we're going to make sure that we reflect those things in the NANDA diagnosis. Potential for self-care deficit, hopelessness, powerless, and ineffective coping related to termination of therapeutic relationship. Okay. Whenever you are listing your nursing diagnoses, don't just put self-care deficit, hopelessness. What's it related to? I want to know what it's related to. Otherwise, you're only giving me half of the diagnosis. All right. Outcome identification, nursing outcomes, right? In the orientation phase, it's going to be that the individual outcome, or that the individual client outcome is going to be determined by the dominant themes and central issues that we see. So whatever it is that we have determined or that we have identified as a problem, and what we have prioritized to be most important to least important. In the working phase, the client is going to become more aware of, and they're going to understand their current behaviors. They're going to develop some insight towards the potential causes of those behaviors. I know that the reason I'm not taking my medications is because I know that the reason that I am displaying disorganized thinking, or that I'm becoming, again, so mistrustful of those around me, is because I'm not taking my antipsychotics. Okay. In the termination phase, the client is going to gain some sort of symptom relief or attempt limited behavior change. So they're going to make some progression towards improving their overall situation, right? They're going to agree to continue to work towards that, and they're going to achieve all measurable personal behavioral changes. Planning and implementation. Okay, so now we have done assessment, we have identified our nursing diagnosis, now we want to plan and implement. Okay, in the orientation phase, it says we're going to tune into process, not content. So that means that we're going to pay attention to all nonverbal as well as verbal behaviors. Okay, we're going to respond to the things that we have identified. We're going to view them as themes, the things that we see like anger or hopelessness and even powerlessness. Those are going to be, we're going to look at those things in order to help us to determine what is going to help to improve that behavior, what is going to help to change that behavior, what do we have to plan and implement in order for that to either decrease or to be eliminated. Address the client suffering, directly address the client suffering within the context of their cultural and ethnic background, and allow them to be able to share how they see or how they experience or manifest their problems. This is why I believe that, or the reason that I do this is because okay? And then, of course, we want to make sure that we're clarifying the purpose, the roles, and the responsibilities before we start to implement something. We want to make sure basically that we understand. We want to make sure that in the orientation phase, this is where we said what? That we determine what our roles are, what we're going to do, what our responsibilities are. Okay, so in this planning and implementation phase, we're going to go back and we're going to review that before we implement something. In the working phase, we're going to look at problem-solving strategies. So we're going to look at the things that we're going to incorporate in order to be able to solve the problem, so to speak. Remind the client that these problem-solving abilities sometimes take a little bit of time. You don't just know how to incorporate problem-solving strategies that you've never seen before. Okay, and we're going to use some active experimentation. So we're going to use them, but we're going to understand that we may need to make changes, or we may need to boot the whole thing out. Sometimes that just happens, and we have to be able to do what? To work through it, right? Challenging client resistant to change. Remember that that's very typical, because change is difficult. It is anxiety causing. Examine thoughts that are going to cause the client to have a decreased sense of self-worth, or affect their ability to be able to control and express emotion appropriately. So some of those acting out behaviors that we might see, as well as their ability to be able to relate to others in a meaningful manner. So the relationships that they have with how it's going to be affected. Challenging client resistance to change is a big one that we run into when it comes to planning, into the planning and implementation of whatever our nursing diagnosis is in that working phase. Why? Because we have to look at truly, again, what's causing that resistance. Why is it that they don't want to change? And we said that's major work in one-to-one relationships, is being able to identify those things. Not just be able to know that they exist, but we need to know why they exist. Why do they exist? What's causing them? What's contributing to them? And then we have to make sure that while we're looking at all these things and trying to come up with solutions, that again, that we're not leaving out who? The client. We're making sure that we're looking at their values and we're looking at their religious beliefs, because they may interfere with this constructive change. If we're trying to incorporate a change that goes against what they believe in or goes against their values or the things that are important to them, how likely are they to make that change? They're not. They're going to be resistant to that change, even if it's a needed one. All right, planning and implementation in the termination phase. Okay, so this is where we are doing what? We're preparing for that therapeutic goodbye to them. We're ending the relationship with them. So what are the things that we need to consider and we need to plan for as far as and implement? Things like understanding that the patient may experience fears of abandonment. For a lot of these clients, because they have had that in the past, we need to make sure that they understand that that's not what we're doing. We need to make sure that the transition is a smooth one for them. We want to focus on the good things. We don't want to focus on the things that they still need to do. We want to focus and emphasize the growth that they've already achieved. Wow, look at everything that you've already done. You have taken your medicines every single day since you have been here. You have participated in group every day that you have been here. You are able to tell me the major side effects of your antipsychotics and of your antidepressant medicines, etc., etc. And then we want to continue to focus on the realities of separation. I know that it's going to be tough for you when you leave here, but you can do that. You're still going to have your monthly visit where you're going to go to see your mental health worker that you've been seeing for years. You're still going to be able to go out there and see them. You're still going to have your group therapies that you're able to go to and to participate in. Okay? Making sure that they understand that, although you can't be here forever, although we can't continue this professional relationship forever, you're ready. And these are the things that are in place in order to make that possible. Okay? And then mutual planning about where and how to seek future help if the need arises. Is it okay for you to tell them that they can contact you? If you're in an acute care facility, no. However, it is not uncommon for a client, especially ones that have gone through this before. They know your name. They call up to the facility. They tell you, Miss Carrie, this is so and so and so and so. I'm really having problems with doing what we talked about in group. I'm having problems staying on my medications. Is it okay for us to direct them what to do? Yes, it is. Telling them, you know what, Mr. Leverett, you need to make an appointment with your mental health worker. It's okay for us to ask them, are you having feelings about hurting yourself? Asking them a few questions, because it helps us to direct them. Okay, helps us to let them know what they can do in order to stop this from becoming worse. All right, and lastly, client evaluation. So the last step of the nursing process when it comes to orientation phase, working phase, and termination. In orientation phase, remember that we do client evaluation, we do evaluation at the very beginning, right? So initial comprehensive evaluation of client behaviors. We do this at the very beginning as well as looking at it again in the end. The initial steps towards the development of client self-evaluation. We set it all up in the orientation phase so that at the end the client can actually look at himself and be able to do some self-evaluation. In the working phase, we look at what we call on-the-spot evaluation. So let's say that we've implemented a behavior change, and we are we're noticing that there are some concerns about it. So addressing it right then and there. You know what, I think you're really struggling with this, or you appear to be struggling with this. How do you feel about that? What do you think we can do about it? Okay, and then mutually evaluating the degree of the client's success in being able to achieve specific goals and even the progress towards regarding growth producing or growth inhibiting behaviors. So looking at the things that are going to be beneficial for them, as well as being able to identify the things that are going to keep them from achieving their goals. And lastly, in the termination phase, of course, is going to be based on goals that are formulated in the orientation and working phases. Okay, so termination phase, we're going to be evaluating them based on what we deemed was going to be important to evaluate at the end in the beginning. So at the beginning, we said, this is what we're going to evaluate in the end. Okay, so that's what we're going to do in the end, is we're going to look at those goals. We're going to look at that and whether or not that we met those goals. Okay, so, and what are we going to do? We're going to evaluate each goal, and we're going to do it in terms of measurable, observable behavior. So things that we're actually able to see and to evaluate on that client. Okay, that is the end of Chapter 4. So we will hopefully have a much better day Monday. And this is going to be, I will post a link, because I'm not sure if you'll be able to just go into this room. I think you might actually have to have a link in order to do this, but it is recorded, so we should be good to go. And I will post that for you, and we'll see you all Monday morning. Page 152 are your defense mechanisms. I want you to be sure and look at that. You may see some of that again, and you are definitely going to be using those when you go to your outpatient clinics. I want to know about your any defense mechanisms or any defensive behaviors that you see in your client. So you need to know what they are, okay, or what some of them potentially are that you will see. All right, have a great weekend. You should be able to start this and stop this as needed. So I hope that this will be at least a good backup plan. Have a great day, and I'll see you all on Monday.